So now we're going to be doing x-ray positioning for the lower leg and the knee. First, I'm going to be showing the AP of the lower leg. Now, this is going to be AP position and a line through the malleoli, parallel to the film space. We're going to be using a 14 by 17 cassette diagonally. And the central ray is directly perpendicular to the shaft through the center of the field. The AP projection of the tibia and fibula include both knee and the ankle joints if possible. So, obviously, right now this is a 10 by 12, so imagine it would be 14 by 17, sorry. Next, we're going to be doing the lateral. Now, in this case, you can have the patient, I'm going to be using my left leg. Here we go. Again, with a 14 by 17 cassette, a line through the femoral epicondyles will be perpendicular to the film plane, and the central ray is located perpendicular to the shaft through the center of the film space. Here we're going to see a lateral of the tibia fibula and both ankle and knee joints if possible. And if it was a 14 by 17 cassette, it'd be a lot easier to be able to actually view that. For the next routines, they're going to be for the knee. For the A to P knee, the patient would actually be standing, but since I have my phone, I'm going to be having it laid down just to make it easier so I don't have to hold both. And an AP for the knee, the patient would be standing, the knee is fully extended, and it says internally rotate the leg about 5 degrees. The patella should be centered over the femur. And the central ray, if the patient is recumbent, the central ray is about 3 to 5 degrees when imaging the joint space. Central ray is perpendicular when performing the radiograph of the distal femur and proximal tibia and fibula. And for this, we're going to be seeing bones and soft tissue of the knee, including the distal femur and patella, proximal tibia and fibula. For the next view, I'm going to show you, that's going to be a knee medial oblique. Now, in this case, if you can see the foot, what they want the patient to be is rotating the leg internally to about 45 degrees. With the central ray, if the patient was recumbent, the central ray would be 3 to 5 degrees when imaging the joint space. If I'm upright, the central ray is perpendicular when performing the radiograph. But either way, in both scenarios, the central ray is a ½ inch below the apex of the patella through the center of the field. For the lateral oblique, instead of internal rotation, you're going to have an externally rotated foot, 45 degrees, going the opposite direction. And in this case, recumbent, you're doing, again, the 3 to 5 degrees of the joint space. And if upright, it is perpendicular to the distal femur and proximal tibia and fibula, but still a ½ inch below the apex of the patella through the center of the field. So the biggest difference is the internally and externally rotation of the foot. Or leg, if you'd like to say. Now we have the lateral knee, and in this instance, hopefully it's observable. Let's get some of the light right here. Now for this one, the knee is in a true lateral position, and the image, they say to flex the affected knee about 20 to 30 degrees. For the central ray, it should be directed about 5 degrees cephalic to the knee joint. The central ray enters a ½ inch below the medial epicondyle through the center of the field. Now we're going to do the tunnel. And for the tunnel view, you could be laying down or have the patient standing with their knee slightly bent. Or you have the person laying down, their leg flat down, and the knee raised up slightly with that angle. Now, for the tunnel intercondylar fossa knee, the patient's standing PA, and the legs is flexed approximately 40 degrees. Central ray is perpendicular to the lower leg and a ½ inch below the apex of the patella. For this, they actually use a 10 by 12 image receptor. And last but not least, the tangential patella. Now for this one, this one, the knee is actually going to be flexed 45 degrees. They also call this the sunrise-sunset skyline. So in this instance, there's definitely more of a flex position of the knee closer to the buttocks, where the previous one was a lot smaller of an angle. And for the tangential patella, we are positioning the slowly flex with the knee as far as possible. They can use tape or use gauze or some strap to hold the leg in that position. And the central ray cephalad, so there's a 45-degree angle between the lower leg and the central ray. And the cephalad is about 10 degrees with the patient lying with the knees bent. And here we're going to be seeing the patella and the space between the patella and femur.